Dear guests, this is Bridget from the University of Hong Kong JCJoyAge project. Good morning, good afternoon, and good evening, depending where you are joining us from the world. Welcome back to JCJoyAge International Symposium 2021. This is our fourth day and also our final day of the symposium. Before we start, I would like to thank our speakers for their generosity of allowing us to record today's session and make the resources online later. Yesterday, there are audience asking where they can find our resources, so you can follow the link in our chat box and find our research website there. We'll be uploading the speakers' videos later. And to our audience, you're more than welcome to share this to your colleagues and fellow researchers. Should you have any questions for our speakers, please do not hesitate to type in and send us through that chat box anytime during the presentation. We will collect these questions and address them later in the Q&A session. So far in the symposium, we've learned about WHO's Healthy Aging Framework, caring for people with dementia and their carers, the relationship between environment, social participation, and health. Today, we're going to focus on the non-pharmacological interventions for older adults with mental health needs and the clinical training programs designed for frontline practitioners who are addressing those needs. For this topic, we're more than delighted to have two clinical psychologists with us today. Professor Rebecca Allen from the University of Alabama and Ms. Kwok from the University of Hong Kong. Professor Allen is a professor of clinical general psychology, and her research and clinical interests include interventions to reduce the stress of individuals, family, and professional caregivers for older adults with advanced chronic or terminal illnesses, and the dynamics of healthcare decision-making. Today, she is going to talk about an integrated care training program to care for people with substance use disorder. Professor Allen, please.
Thank you so much for that lovely introduction, and thank you as well for the invitation to speak with you here today. I'm so excited to share this work with you. Let me share my screen. Okay, and I'm hopeful that everyone can see that. It worked well in the test run that we had a bit ago. So today I will be speaking with you about a project that we have at the University of Alabama focused on training our graduate students in the prevention, assessment, and treatment of substance and opioid use disorder in midlife and older adults. So I'll be describing the Deep South Integrated Care Training Program, and I'm just delighted to be with you today. This particular project is funded by a grant from the Health and Human Services Administration, specifically the Health Resources and Services Administration. So thanks to our funder. As well, thanks to several members of my team, including Drs. Tricia Whitty and Lindsay Jacobs, Brian Cox, Kirsten Hill, and Haley Potts. Kirsten and Haley are two of our trainees who have helped contribute to this presentation and our ongoing work. This presentation today will focus on these learning outcomes, and in particular, I will be describing our training program as it relates to substance and opioid use in one region of the United States, the southeastern state of Alabama. I'll talk with you about factors to consider when screening and treating these disorders in adults at midlife and later life. That's going to be a particular focus. Another particular focus will be issues of trauma. I'll also give you a little bit of a taste of our data, the clientele that we're working with. I'll describe challenges in telehealth delivery. I know many of us have grappled with that since the beginning of the global pandemic. And I will, if we have time, give a couple of case descriptions of our older clientele, and we may even have an opportunity to practice a little bit of mindfulness. So, a little of my background, I am a first-generation scholar. That means that my upbringing was such that no one had ever gone to college in my family before. Nod to my parents, picture it here. And I was the child of older parents. My father was 54 when I was born. My mother was 40. My undergraduate is from University of Kentucky. I got my doctorate at Washington University in St. Louis as my friend and colleague Terry Lum. Postdoc at Penn State, and have been at the University of Alabama the majority of my career, engaging with students, colleagues, and community partners. So I started the work with community partners and community-based participatory research engagement back in the early part of my career when I was focused on palliative care and palliative care interventions for dyads of patients and their non-professional or family caregivers, and was funded by National Institute of Health to continue this work. Basically, it was a reminiscence or dignity therapy program in which we started with trainees and then progressed to training community volunteers to conduct the reminiscence sessions with older patients and their family members. And it was just a 3-session intervention where the family would be assisted in choosing a topic of life to focus on, and then creating a representation celebrating that older person's life. And the second session was working on the project, and the third was sharing it with the volunteer and forming a plan on how to share it with other family members. So that really introduced me to community-based partnerships and whetted my appetite for how important it is, if our work is to be meaningful, to engage, learn from, and do work that helps the community. So across all of the projects that we've conducted, we did find that we helped the patients. They improved in their emotional symptoms, the number of symptoms, and the bother they experienced from those symptoms. We helped family caregivers find more meaning in life, living an engaged and purpose-driven life. We helped the volunteers who were trained to work with the families to create legacies such as a memory box or cookbook. And the volunteers really reported wanting to do more and wanting to volunteer with other families. So that work started me in the line of thinking about community partnerships and how to really disseminate our care. And in order to do that, whether we're working with families with dementia or other chronic illnesses, or people in the community with substance use disorders, one model, and this is purported by SAMHSA and HRSA in the United States, it is a model of integrated care. So working with clinics and healthcare providers in one of these formats, with the goal being you move across from left to right from a coordinated care model where there's little collaboration in an interdisciplinary or interprofessional fashion, through co-located, where you may have different professionals in the same building working with patients and families, all the way to integrated care, where practice change occurs and psychologists and social workers and physicians and nutritionists are all taking a team-based whole person care approach. And so our goal in this training program is to move our partnerships from these lower levels to the integrated practice change level of care. A nod to our clinical training committee, along with myself, Dr. Martha Crother is a co-principal investigator, and then we have a large and interdisciplinary training committee with various expertise. Matt Jarrett is actually a child psychologist and our director of clinical training. Josh Iyer is in the School of Nursing. Jim Hamilton is a health psychologist or behavior medicine specialist. Lindsay Jacobs does capacity evaluation. So does a person who is older and might have cognitive or health-related, age-related decline in thinking skills, are they able to make decisions with regard to their care? As well as someone who is using and misusing substances like alcohol, marijuana, benzodiazepines, opiate medications, are they able to participate effectively in their own care? Bob McKinney is a social worker. Tricia Whitty is a specialist in substance and opioid use disorder, and Dr. Toya Burton is, in fact, a chiropractor. So just a little bit about the area in which we are practicing. It is, as I said, a southeastern state in the United States. And the patients in these areas, we work primarily in 2 counties, Tuscaloosa, the home of the University of Alabama, and Walker, which is a rural county. You can see that the counties vary in terms of race, ethnicity of people who live there, with Tuscaloosa being more diverse and Walker County being largely non-Hispanic white. The poverty levels are significant and greater in our rural clinic. People, a significant portion, are uninsured, and excessive drinking is, it's just not true. And you'll see that in a bit when I get to our data. As well, people in these counties experience a good number of disparities regarding internet and web-based application access. It's hard to use the internet. It is also hard because this area is a health and mental health provider shortage area. A little bit more about our specific clinic. So here's a picture of the state of Alabama in the United States. And the red area is Walker County, where our rural clinic is, Capstone. We're also at Watley, so that you have a greater idea about our clinics. The rural clinic, Capstone, has a medication-assisted treatment clinic for opioid use disorder. It is a fully integrated care facility with on-site psychiatry, social work, nursing, etc. And they are just hungry and excited. We are fully integrated into the electronic medical record system. Watley Health Services in urban Tuscaloosa is a clinic you might think would have more resources, but in point of fact, we are not in the medical record, and we seem to be practicing in a co-located, same building, but siloed system of care. Both of these are what are called in the state's federally qualified health centers, and that means they are designed to treat poor, uninsured, under-resourced individuals. So the project is designed to work with the least of these. Phoenix House is a third site that we have acquired along the way, and it is in fact a residential treatment facility. And you can see from the picture that it is not posh. Again, our focus is on low socioeconomic status individuals in the community. It is what's called a level 3 residential care facility. It focuses on group counseling, voc rehab, helping people find jobs, improve or finish their education, assist with life skills training, and literal job placements. A lot of what we're doing here involves our group work with mindfulness-based relapse prevention for substance use. We do a lot of cognitive behavior therapy interventions for substance use and chronic pain, which can be a gateway to opioid misuse. And we do a good bit of trauma-related therapy in this setting. As well, we got to Phoenix House through the Watley Clinic, and the people who live at Phoenix House receive their medical care at Watley. Tell you a little bit about what we're doing. We have what are called clinical champions at both of our treatment sites. So again, it's a partnership with the clinic, with the community, with the people out in the field, like many of you are. All of us pointy head academics aren't seeing patients, 40, however many hours a week, full time, right? So we partner with a clinical champion at each site who helps us acquire cases, find the people who need our care. These clinical champions introduce our free program. All services are provided by that federal grant, and describe the different options that patients in that clinic or in Phoenix House may access through us for free. Then our team conducts consent for research participation, and we do a baseline screening on everyone that has a good bit of behavioral health information, as well as cognitive information and health literacy information. And I'll speak to that in just a bit. Immediately after the baseline, all the people that we see receive feedback about issues they may be having that are related likely to their substance use, including depression, trauma, anxiety, other issues. We talk about that. We talk with them as well about their cognitive functioning and their health literacy. And health literacy is how well they're able to really interact with their healthcare providers and make informed and shared decisions about their healthcare. Our treatment consists of brief interventions and then, expert training, talking about referrals and referral to treatment for longer treatment. Some folks we can't see on the grant. Those would be the really seriously mentally ill folks who might need inpatient care. We're not providing psychiatric care, for example. We also give individual treatment, again, substance use focused, but encompassing all the issues that a person may struggle with. And then those groups that I described earlier, mindfulness, again, focused on relapse prevention, health literacy adapted pain management, cognitive behavioral pain management, and trauma. So with a focus on our Capstone Rural Center, we have 2 trainees each year placed in this site. This project is in its 3rd year now, so we are training our 8th through 12th trainees, graduate students, and we are hoping to get renewed funding this year and keep on trucking. What we found with our rural clinic, I talked with you a little about that earlier. Some of the strengths are that the rural clinic had pre-existing, pre-COVID telehealth delivery systems that were well integrated and well used, a very supportive behavioral health focused staff. They started a medication assisted treatment program for opioid misuse. We are integrated in their electronic medical records. There is a psychiatrist, etc. They also really wanted to start a peer coaching program, which is a step more than having a sponsor in 12-step substance use work. And so we're working with them on that. Issues being getting the clients to the treatment site. Transportation is poor in this rural area, and the United States is poor in general. The southeastern United States, even more poor in terms of public transit systems. There are as well a number of mining and logging communities, a lot of physical labor, a lot of injuries that occur in these manual labor jobs, and that can be challenging. Whatley, the strengths are it's a large, diverse urban setting, so the transportation issues are not as acute. Some of the challenges are that it's really busy, and sometimes it can be hard to help providers remember we're here providing free services and we are not integrated into the electronic medical record, which would help tremendously. Phoenix House, the strengths are the need and hunger for our services. The staff have really embraced our training program and our students. We are now integral to their delivery of treatment for their residents. as was reflected in their most recent, what would be called a JCO visit or an accreditation visit, visit by the state. Some of the challenges, though, again, I find it remarkable that within Tuscaloosa, the internet access is extremely poor, worse than in our rural county, and they don't really have an electronic medical record. As a residential treatment setting, their medical care is provided by Watley. So some of the issues that we really focus on in our training program have to do with trauma, and many of you may well be familiar with the Body Keeps a Score, which really focuses on the neuroscience of trauma and how our brains, traumatic events are processed in our brains in such a way that when those memories are triggered, it is as if we are in that traumatic situation in real time, right here, right now. So we really pay attention to adverse childhood experiences, and we have a one-item screener I'll tell you about that is proving to be quite useful in a integrated care, primary care setting. We pay attention to not only prior childhood trauma, but current trauma, current experiences of post-traumatic stress disorder, and then we provide trauma-based services co-occurring with substance use services. We operate as if every client we see has trauma, just being mindful as providers about that, prioritizing their safety, and you can see all of these issues with regard to telehealth delivery get more complex. We really honor the situation that trauma can be influencing their present functioning, but highlight client strengths and really try to build their resilience. So some of the issues with regard to our work in integrated care is cohort related. So experiences of trauma and willingness to talk about trauma varies by one's age, by the conditions in which one was raised. As well, we are aware of secondary traumatization of healthcare providers, of our own trainees, of ourselves, of the partnering clinicians with whom we work in our settings. Okay, so this is a slide I wanted for sure to describe to you as an example of our trauma awareness in providing substance and opioid use treatment. Our screening includes just one question. So this is something that any physician, psychiatrist, nurse could incorporate in their care. And that question is, how would you feel if you learned a child that you care about was growing up exactly in the same conditions that you did? And the response options, I'd feel happy about it. I'd feel, okay, neutral. I'd feel kind of sad and angry, or I'd feel very sad and angry. And our cut point here is really anything other than happy. We also do pull neutral away from sad, angry, and very sad, angry. What we're finding with this simple one-item screener is that it maps on well to the longer assessment for adverse childhood experiences and to present-day post-traumatic stress disorder symptoms. We are mindful of providing feedback in a private setting when we're in person. Of course, we're mindful of our Zoom connections being both secure, confidential, and as keep that patient information as confidential as possible. Said all of that. Okay, so in the realm of telehealth, as we've all experienced during the global pandemic, we are increasing our focus on home environmental safety. So we want to know where our client is when we're interacting with them through telehealth, telemedicine, telepsychology, right? Where are you? Are you in a safe place? Are you alone? Are there other family members around? Are you also watching television? Can you turn the television off? Those kinds of issues. Conducting mindfulness-based treatment via phone is challenging. It's better when you have a video link such as Zoom, and that too presents challenges within trauma, which we'll get to. So some of the challenges we have seen are in relation to the ethics of providing services to and through organizations. Is our client the individual in front of us or the clinic with whom we work? Who owns client-based information? We're not in the electronic medical record system at Watley. So we don't pay our participants, but we offer free services, and we do have subcontracts with our clinics. We lost one of our planned treatment sites completely due to the overwhelmed experience of being healthcare provider during COVID. The providers couldn't have us there because they were busy getting vaccine shots in arms and treating patients and doing other things. So we had to drop one planned location of our training. With regard to our focus on the lifespan, we define older adult as many in the substance use community do as 50 plus. So I qualify as an older adult. We also differentiate high-risk substance use and focus on that in addition to formal diagnosis of substance use disorder. And with older folks, the diagnosis can be challenging. That's another reason for really focusing on high risk as opposed to just a diagnosis. One interesting thing is about early versus late onset. We find, as I mentioned, in some of our clinics, we have older folks who have had very physically labor-intensive jobs, and often older people who have not had a lifelong substance use issue come to the problem through an injury causing chronic pain, causing opioid prescription, causing opioid misuse. So we are seeing an increase in the prevalence of substance and opioid use among people who are in their 40s and 50s, and a lot of that has to do with the health behaviors of different age cohorts. And I know you guys have been talking about age cohorts throughout this conference and are well aware of the differences related to cohort. When you are working with older people on substance and opioid use, with those cohort issues, there may be increased stigma that people are not as willing to discuss their drug and alcohol use with young folks. You have to think about the comorbidity of laying on treatment of, say, pain with an opiate when there may be other co-occurring illnesses. You know, the longer a person lives, adverse childhood experiences may be in the more distant past, but also we may have increasing difficulties in inhibiting unwanted information, back to the cognitive changes that occur with aging. So adverse childhood experiences may actually present in late life, just as they have presented earlier in life. Loneliness and then suicidal ideation also are associated with substance use disorders among older adults. So a little bit about our client data, and then we'll get to some fun discussion about some cases. We have so far in the first 2 years, and we are now in month 3 of year 3, we've seen a total of 132 patients, about even split between men and women. And most of them have either been at our residential treatment facility, Phoenix House, or the rural clinic. That's that red highlight there. You might notice that our age group distribution has been fairly consistent, although the largest numbers are people either in their 20s or 40s. We have over 17, almost 18% who are 50 plus, and roughly 25% to 30% in their 30s. So we have a healthy percentage of older folks to consider age differences. Our entire population of 132 clients across the adult age range exhibit these characteristics. 79% of our folks have stated that they have difficulty with transportation, difficulty accessing services in what is already a health and mental health provider shortage area. So if the services exist, patients have a hard time getting to them. Of the people who have some form of transportation, 67% say they limit their activities because transportation can be challenging. You can see there's a large number with early life trauma. And while alcohol use isn't that much of a problem, so to speak, with only 22% exhibiting alcohol use, remember that demographic population-based data I showed you earlier, but look at drug use. Everything other than alcohol. So 96% of the folks we see report moderate or substantial or severe use of benzodiazepines, cocaine, crack cocaine, opioid use, marijuana, other stuff. You can see that 45% indeed report opioid use disorder. And we're mandated to see 25%, so we are meeting that goal. About a third have physical symptoms that are comorbid with their mental health issues. 70% depressive symptoms, 87 anxiety, 62 PTSD. Of note, we were surprised to find that cognitive functioning in this group is, there's a substantial number of people who are diagnosed with mild cognitive impairment. Part of that is in relation to the quality of the education that people have received in these areas of the United States. Part of that is in relation to the literal brain damage that has occurred over time with regard to their substance use disorders. Looking at age differences, we find that there is no difference in our group in terms of substance misuse with regard to age cohort. So our 50 plus are in as good or bad a shape as our 20-somethings, 30-somethings, and 40-somethings. Of note, the age groups with the most health complaint are in fact those in their 20s and then 50 plus. Our clients in their 20s and 50 plus report more severe symptoms of depression and PTSD. And overall, older age was associated with greater somatic or physical complaints, which you would expect as we accrue injuries across a lifetime. In terms of telemental health challenges with older adults, and benefits. So there are benefits. Let's start with those. It's always good to focus on the positive first, right? So the ability to integrate telemental health services reduces need for transportation, emergency room visits, hospital admissions. In fact, providing treatment in in-home settings reduces depressive symptoms, and in a familiar setting, you get the best of a person's cognitive functioning. It's familiar. It is true that, older people may not have as ready access to technology, and certainly in our low income, low resource patients, they might not even have internet access in their community. So lack of access to things like Zoom, low digital literacy combined with that low health literacy, even in some of our communities, poor telephone access can be a problem. Okay, so we have in fact gotten to that period of time where I can tell you a little bit about some of our cases, which is more fun. And I know we're holding questions at the end. But while I'm talking about our cases, maybe we can all, I know I can't see you, but take a breath and let it out and just touch your fingertips together and get a little present in your body. So these two individuals I'll tell you about were seen in our Tuscaloosa or urban clinic. One of our clients, M, was a 59-year-old African-American woman, and she came into a substance use problem issue through having chronic pain related to injuries. So she came in after having been prescribed by her primary care physician an opiate to treat her chronic pain. Our treatment approach with her, because she had that low digital literacy, was to do brief check-in telephone calls. And our focus with her in her substance use trajectory was on pain management through behavioral health means, such as perhaps mindful meditation. A second client in our urban setting is Kay, and he was in our residential treatment facility, 56, history of alcohol and stimulant use, so cocaine, Adderall, other stimulants. His PTSD stemmed from traumatic events he had experienced while incarcerated in prison. Of course, we know the United States has the highest rate of imprisonment of any modern country. And with this individual, we were able to use internet-based Zoom delivery, but we were not, for cognitive and health literacy and mental health literacy reasons, we were not able to use manualized CPT. Instead, we backed off of the cognitive component and the trauma processing steps in CPT to use just simple exposure techniques as events would crop up during session. Again, all related to and driving that substance use disorder. Finally, our rural client, as I wrap up here, I actually made my presentation a little short in case we had questions in the middle. So Y was a client in our rural clinic, that capstone clinic. So majority non-Hispanic white, rural, low income, low ed folks. And Y was a 50-year-old woman who had a trauma history. She was stable in her recovery. She had misused pain medication for 3 years, but had been on Suboxone in the medication assisted therapy program for 3 years. So she was maintaining her sobriety pretty well. Her treatment with us consisted of biweekly telehealth phone calls and some in person, but notably she was accompanied to her visits to the capstone clinic by a family member. And that is often an issue that we see that can surprise primary healthcare personnel who aren't used to dealing with individuals of the older age range with age-related cognitive changes or mild cognitive impairment or even dementia, because, you know, people, healthy adults tend to go to their own health appointments without family members present. So, so helping the clinic staff learn how to interact with the client and not her adult daughter was a part of our work. We also focused on smoking cessation. And one issue in the states, in Alabama in particular, that comes up fairly frequently is how, as a psychologist, how do you train psychologists to work with whole person strengths, such as a strong religious faith. A lot of the rural folk and a lot of folk in Alabama in general are very religiously faith-based, involved individuals. And so we have the opportunity to focus on church in the Judeo-Christian tradition as a part of recovery and coping. And that's a cultural issue that we can focus on with our trainees. Okay, so that's actually all of my presentation. So I hope that I've helped tell you a little bit about our training program at the University of Alabama, our focus on working with providers and community members, that community-based participatory research It's translational. We want to take evidence-based treatments and bring them out into the real world practice settings in an integrated care clinic. And we are very aware in our substance use training program of two primary issues: trauma history leading to current trauma symptoms and how that interrelates with substance use. And also, as all of us with JoyAge conference know, age and cohort. Developmentally, there are shifts in our motivation that help us respond to certain treatments like ACT and mindfulness, perhaps in a more positive way. And as well, that cohort influence that might yield a difference in terms of stigma and willingness to discuss certain issues. So thank you very much for your time and attention, and that is the end of my presentation.
Well, thank you, Professor Ellen, so much for walking us through the Deep South Integrated Care Training Program, improving mental health of older people, the strengths and challenges you mentioned, different settings, especially how digital literacy and access to tech gadgets come into play, especially in this digital era. Well, now let's shift gear and hear about the local experiences in Hong Kong. To speak on that, we have Ms. Kwok, a dear colleague of mine who received her clinical training in University of Melbourne, who has been practicing in the field for over 10 years, and she is now the project manager on the clinical side of the JCJoyAge project. Today, she is going to share with us a non-pharmacological intervention designed for older adults with chronic pain, which is now being piloted in the JCJoyAge project. Ms. Kwok, please.
Thank you, Bridget, and hello, everyone. Let me just share my screen, and hopefully it goes well. Hopefully everyone can see it. So I'm very happy here today in this symposium, especially today is the last day of the symposium. So a bit of myself. I'm YY, the senior clinical psychologist from Hong Kong University, and I'm also the clinical project manager for the JCJoyAge project. So today I would like to take the chance to share with you our local experience in developing a pilot intervention for older adults who suffer from the chronic pain. And in particular, we are trying to use ACT, the acceptance and commitment therapy, combined with the physical exercise for this community-based intervention program. So before I get into the sharing, let's think about the chronic pain. Since it's very common, perhaps many of you may already experience with this or even may have chronic pain now. For others, since if you can imagine yourself having chronic back pain or knee pain, that you are no longer able to do what you used to do or used to enjoy, and your mobility is limited by the pain, how would that make you feel? Or what do you think your life may look like? So my guess is happiness, passion, or a life that is fulfilling and meaningful, probably are not the first thing that come to your mind. And actually, it's very common that people who experience chronic pain feel frustrated, angry, depressed, and live in a life that far from their satisfactions. So by saying chronic pain, we are talking about the pain that lasts for more than 3 months. And some local studies in Hong Kong has estimated there may be up to 900,000 older adults in Hong Kong have chronic pain. So there's a lot. And chronic pain and depression are the risk factor to each other and often coexist. Also, the chronic pain and depression are the most common factors that contribute to poor functioning and treatment outcome, and also decrease the quality of life in our clients. And as we know, it is extremely difficult to cure chronic pain. That means very often that the pain will persist. So with this in mind, we start to ask a question. Given the chronic pain probably will persist, how can we facilitate our older adults to have a life that they are passionate about, a life that they are looking forward to and find it meaningful and fulfilling, even though they are having this pain. So with these questions, we then start our little journey of developing a community-based intervention program that aims to promote a valued living for older adults suffer from the chronic pain and emotional distress. And here you can see the picture. They are my Hong Kong youth colleagues who we work together to develop this protocol. So you can see from there, Angie and Rachel are the ACT facilitators, and they are the clinical psychologists and counselor by training. And Annabelle is the key person. She is our certified exercise physiologist that help to design and supervise the physical exercise part of the program. And we also work with the social workers from the district elderly community centers from different NGOs when we conduct the pilot group as well. So for today's sharing, I would like to share the conceptual framework and the design of our protocol, and also share some of our learning from the pilot groups we conduct, especially on the cultural challenges and the adaptation in applying ACT to older adults in Hong Kong. And at the end, I will also share very preliminary result and feedback from this group. So when we talk about non-pharmacological intervention for chronic pain, currently the most commonly used model for chronic pain intervention is the biopsychosocial model. This model highlights that the chronic pain is not simply a physical condition. Other psychological and social factors like mood, perception of control, fear of future, and social isolations are also contribute to clients' day-to-day pain experience and their pain intensity. So therefore, intervention for chronic pain often involve multidisciplinary approach. Most of the long-term interventions are aiming to reduce the pain intensity as well as its influence on the functioning. It's important that we are not just focusing on the pain intensity because sometimes it can backfire. As we said, the chronic pain is extremely difficult to cure, and if we're only focusing on the pain alone, this may create even more frustration and helplessness in clients, as they may find that the pain can't be cured or controlled. So therefore, it is important that we are also focused on improving clients' functionality and valued living, even though they have the pain. And recently, the NICE guideline has updated their recommendation on the management of the chronic pain and suggests that both supervised group exercise program and the psychotherapy, such as CBT or ACT, are effective in improving clients' pain experience and functionality and their quality of life. So since most of these studies have been done in hospital or in pain clinic setting, we would like to develop a community-based intervention program and also explore if combined ACT with physical exercise can reduce the pain interference, reduce the depressive symptoms, and also improve our older adults' engagement in the meaningful life. So before I go on to share our experience and learning from the pilot group, let me give a very brief overview on what is ACT and how this may be helpful for our chronic pain clients. So ACT is a mindfulness-based intervention approach that aims to promote psychological flexibility and develops workable goals and strategy for valued living, even though we are facing challenge like chronic pain. This idea is particularly relevant to our older adults as the functional declines that are associated with aging and chronic pain may limit the previous value goals. And ACT promotes the flexibility that focuses on the workability, on how to live a life consistent with value, and allow older adults to develop more value consistent goals and alternative strategy to achieve them. So in ACT, actually 6 processes are involved to build on the psychological flexibility. But given the time I have today, I probably won't have enough time to go into details for each process. Just to simply put, we can categorize this process into two major focuses. One of the focus is on the willingness to experience pain without attempting to control or to change it. And in that, the key processes are the mindfulness and the acceptance. And in it, acceptance is defined as allowing the difficult thoughts and feelings to be there and willing to experience them for the sake of the values. The second focus in this ACT model is on clarifying clients' values and goals and their commitment to the value consistent actions. This focus is more on the behavioral side and aim to create the behavior changes. So the key processes here is the value and value consistent actions. So by working through this process, ACT actually can help clients to build their psychological visibility. And in chronic pain context, that means that painful sensations, feelings, and thoughts are accepted, that the attention is focused on the opportunities of the current situations rather than on ruminating about the lost past or catastrophizing about the future. And that the behavior is focused on realizing valued goal instead of pain control. And studies has already found that psychological flexibility is associated with better functional capacity and increased well-being, both psychological and physical well-being. And also it helps to improve pain intensity, depression, and the quality of life. So for our pilot program, we believe that ACT will be helpful for our older adults. And we also believe that it's beneficial to combine physical exercise with ACT, as they can complementary to each other. For example, by connecting to one's value and distance themselves from the self-defeating thoughts, such as I can't do it, older adults may be more willing to do exercise and also willing to accept the discomfort that may come with the exercising. On the other hand, the exercise session can already be part of clients' commitment toward their values and also provide an opportunity to practice psychological visibility. So, and also in Hong Kong, psychotherapy may be something that is too novel to some older adults. And having exercise sessions in our program may actually help older adults to engage more in our program and also help to reduce the stigma as well. So therefore, we developed this 8-week program that aims to reduce the pain interference and depressive symptoms in chronic pain clients. At the same time, also aim to improve their engagement in the meaningful life. So for the pilot group, we recruit older adults in community who are aged over 60 and has chronic pain with mild or above depressive symptoms. And for the program, each week we have 2 sessions. One is the ACT session that lasts for 2 hours. The other is the exercise session that lasts for 1 hour. So it's total 3 hours per week. And each session is structured in a way that we begin and end with the mindfulness exercise, which has been found that is helpful to cultivate the acceptance in clients toward their pain sensations. So to develop the protocol, we first reviewed different ACT menus, and then we start to draft a protocol. And we trialed this protocol in 4 pilot groups with total of 22 participants. And all these participants were recruited from the District Elderly Community Center. The protocol is then modified based on their feedback and also the clinician's observations and our consultation with our ACT consultant, Dr. Kenny Fu. We also use questionnaire for the pre-post outcome measurement as well. Okay. And here is our participants' profile. The mean age of these 22 participants is 71 years old, and most of them are female, which is kind of a typical profile we can find in a community center. And it's important to note that more than half of our group members have very limited or even no education at all. So for them, the literacy is very low. And that means that in our group, the literacy level actually varies a lot. And they also experience on average a moderate level of pain severity and interference and depressive symptoms as well. And for their physical fitness, 90% of them are prevail or fail. So with this profile, one of the cultural considerations we have to think about in develop this protocol is the language. So in Hong Kong, lots of older adults in Hong Kong are actually migrated from mainland China. And actually some of our participants speak in different dialects, which may not be easy to understand. And some of them had very limited education or can't even understand any written words. So that is something that we need to modify our protocol for. And most of our older adults are also unfamiliar with abstract concepts like meaningful life or what's it mean by thought and values. So one of the adaptations we made for our protocol is we focus more on the behavioral change process in the ACT model. So in that means that we focus more on the value and the committed action in the ACT process, and this process are aimed for the behavioral changes. So therefore, we are talking to our older client that this group is emphasized on the action base, and we are all learning by doing. So therefore, in our protocol, as you can see, we introduce value and committed action very early on in the protocol, and they are the core elements throughout all the subsequent sessions. So in each session, we will review their progress each week, and we will talk about the barriers that they had in carrying out their committed actions. And in this discussion, it's actually easier for us to highlight other ACT process as well. Another adaptation we made is to simplify the model. So we work from 6 process to 3 ACT steps. That is be present, so noticing what's going on here and now, open up to any feelings or pain sensation that may comes up, but then also do what really matters there in that situations. So we keep repeating these 3 steps in each sessions to help our old adult to remember it and also to consolidate their experience as well. So similar principle also apply to our exercise program. On our exercise program, we teach our client the same set of exercise. So they are practicing the same set of exercise each week, but we increase the number of repetitions in each sessions, so that we are increasing the difficulties and also build on their strength and also confidence in doing so. And we also use lots of pictures and images and local songs. Our older adults really like the local songs that can illustrate the ACT concept and easier for them to understand, and also reduce the reliance on the language and the terminology as well. So the second cultural considerations we need to consider about is the concept of values. Older adults in Hong Kong may not very familiar with the abstract concept of value, but more focused on the pragmatic goals and actions. So for example, they rarely talk about, I want to be a loving person, but instead they may say that I want to cook for my family. So this kind of goal and action may actually become an issue that when the older adult no longer able to achieve these specific goals, due to the decline in functioning or the limitation that they have with the chronic pain. They may feel very frustrated. And also, they grew up in a collectivistic culture that emphasized on social values and expectations over the freely chosen personal values. So for some participants, our group actually was the first time they put aside the family expectation and start to explore what is meaningful to them personally. Another issue that comes with the value is the issue with the acceptance, especially about the willingness. So willingness to have pain or difficult feeling is actually the key to value consistent action. We often say that there's low pay, low gain. And it's true that pain and difficult feelings are always there when you try to do something that is important to you. So willingness is the key. And in this cohort, willingness to self-sacrifice for a greater good is a common cultural value. However, very often the willingness also attached with a strong belief of I have no choice or I have to do so. And that means the action would become more like a tolerating or forcing instead of really accepting and open up for this experience. So for them, instead of having the willingness or acceptance, their action are more like the rule following behaviors. So for the application, we are more focused on the contextualized values. That is the values that they have in a particular situation. And we find that these values are more easier to assess among the older adults. So in our group, we discussed 4 life domains, including self-care, relationship with others, leisure, and self-growth. And we explore their values in each domain. And we find that this actually helped to expand their focus from family-oriented values to other personal values. So some of them did mention that they never thought about their own personal values before. And as you can see the quote here, one participant said that I realized that I forgot about the values and enjoyment I used to have. And especially when I have been busy looking after my family and coping with chronic pain. And the other participant also said that that is the first time I think about my values on self-care. So since this is very new to them, we also find that it actually took more time for our older adults to explore their values on these areas as well. So to further facilitate the explorations on values, we also developed this set of value cards. These cards including different values or goals that we learned from our older adults. And for some participants, especially those with concrete thinking style or people who may not use to explore their own needs, this card actually serves as a starting point of the discussions. And for the willingness, to build a willingness, we actually use a classic ad metaphor of the 2 sides of the same coin metaphor to create this coin, as you can see from the picture. So for this coin, one side of the coin is said pain, on the other side is said love or something you care. So this coin actually help the older adult to visualize what is willingness and what is it for. So that means that although we can't delete the pain, just like we can't remove one side of the coin, it is our personal choice to decide if we want to pick up this coin or not. So this is the symbolic act that the willingness actually come with the personal choices, and it also guided by our values. And one of the example is with this gentleman on the right side, if you can see the picture. So he's a 80 years old participant and has lots of health anxiety and pain. He also has separation anxiety with his wife and very often not allow her go out by herself. So throughout the session, he started to explore his value and find that he wants to be a very caring husband and want to be able to make her happy. So we further build on this by using the con method on his willingness. So for him, one side of the con is the fear of losing his wife, and the other side is his deep love with her. So at the end, he was saying that I'm willing to experience the anxiety of letting my wife go out, as this will make her feel happy, and this is my way of loving her. So it's a very touching, and actually the con become his reminder of his value and the willingness to experience the anxiety as well. And the third cultural adaptation we had is about the stigma associated with the negative emotion. And for our older adults, they believe that expressing negative emotion in public is not appropriate and shameful. So they usually use a strategy like distraction and avoidance to cope. But as we all know that avoidance may actually take them further away from things that are important to them. And the more you suppress the emotion, the more intense it will come back to you. So that's why it's important that we have acceptance in the process. However, the concept of acceptance or the cost of avoiding sometimes may be too abstract for our older adults. So to tackle this issue, we use lots of group dynamics and the experiential exercise to facilitate the sharing and the acceptance. So for example, we adopt this chair sculpture exercise on Dr. Feng's ad menu. And in this exercise, each group member would take turn to share their experience of pain and also their negative emotion. And they also have a chance to listen to others' story as well. By doing so, you actually help them to normalize and feel okay to express the emotion. We also invite them to use their chair to illustrate how they try to control or to get rid of the pain or negative emotion. This allows them to have an in-session experience on how tiring it is when they try to control the pain or the emotion and the cost they are bearing in doing so in their daily life. So initially, we thought that this kind of experiential exercise may be too lawful or strange to our older adults. But to our surprise, most of them were very engaging in the process, and most of them were also able to relate to it in their daily life experience. So these are some of the learning we have along the way when we are conducting the pilot group and development protocol. And for the preliminary results, since we only have a very small number of participants, the results here is only for the reference. But in general, we see that there's an improvement on pain intensity, interference, physical fitness, and also the mood as well. And can also feedback that they found the exercise sessions is great and it helped them to ease their pain. At the same time, because it's easier to remember, it actually helped them to build up their confidence to practice it at home as well. And for the aspect, we see that from the measurement that there's an improvement in the values and also committed actions. And also there's an improvement in the acceptance as well. So some clients actually find that by reconnecting to things that are important to them and able to act upon them, they actually feel less bothered by the pain and feel that life is less limited by the pain as well. So generally speaking, it seems combined act with exercise as an approach to chronic pain is promising and worth to do more. But at the same time, we are facing lots of different challenges, and manpower is always on the top. So at the moment, we are thinking about that when the protocol become more mature, maybe we can train up some fitness volunteers, or maybe in the future, we can have peer lead facilitators to help us to run the group and make the program more accessible and affordable in the community settings. And for the protocol, especially on the ad concept, actually there are still a lot of abstract concept that not easy for our older adults to understand. So we are still exploring ways to deliver the protocol that's more culturally adaptive And if any one of you are interested and has any ideas and wisdom to share, feel free to contact us. So given the time, it comes to the end of my presentations, and I want to thank you, everyone here today, and also the older adults that use their life experience to teach us all these lessons and show us their strength and resilience in facing lots of life challenges. And I hope as a community, all of us can be visible in facing life challenges. And also we all try to create a service that not just focus on the symptom reduction, but also aim to facilitate people to find the passion and meaning in their life. And so that we all have a life that is worth to aging for. So my last look is this one, a bit of promotion. If any of you are interested to learn more about ed, especially how ed can help our older adults to build a meaningful living, we are going to have a professional workshop on the 25th of November. And we are very happy to have Dr. Kenny Fung, a wonderful ed practitioner and consultant, to conduct the training. So you can just scan the QR code and hopefully we will see you there. Thank you.
Wow, thank you, Ms. Kwok. I'm sure the audience would find it helpful to learn the gist of ACT, and the clinical team is actively listening to the community's needs and adapted protocols to be used in the local community. We are all learning by doing, and more importantly, we need constructive feedback for us to improve. And Q&A session is a golden opportunity for us to achieve that. So, dear audience, while we are now welcoming more questions coming in, we have some already in our chat box. May I invite Professor Allen to be back online? Thank you so much for staying with us this late, because I know that by your side it's already quite late into the night. So our audience are in for a treat. We have one question here for Professor Allen. How do you involve community stakeholders in your design of intervention protocols, and especially the older adults? And since you mentioned some of them are clinical champions, do you involve them in the co-design of the protocol?
That's an excellent question. Thank you so much. And I've appreciated the questions that came through chat earlier as well. With regard to involving older adults and clinical champions in our treatment approach, absolutely. So an example, one of our clinical champions, the one at the rural site, she in particular is very involved in the idea of developing peer coaches. So having like a sponsor who is trained in a particular treatment approach to be a support and accountability agent for whomever, older and younger adults, definitely is of interest to our clinical champions. An example of incorporating older clients themselves into the treatment protocol, I think that Ms. Kwok did a great job of talking about that in terms of adapting ACT to the residents of Hong Kong. And we have worked with clients and incorporated their spiritual or religious beliefs into their treatment, working on issues such as acceptance or forgiveness, embracing qualities of life, and thinking about the legacy that the older person will be leaving behind to their children and grandchildren, the important messages that they want to, push forward into the world and into their family. So absolutely, it's important to involve clinical champions and older adults in order to help them be active in their own change.
Thank you very much. I cannot agree more that we need to involve the clinical champions and older adults who might be better in connecting with the service users. I see questions coming into our Q&A box, and then Professor Allen has already addressed them. So for our dear audience, if you want to have an answer to that, you might want to open your Q&A and go there. Okay, so if I may also, okay, here's one more question on, okay, thank you, Ms. Kwok, for sharing on ACT. Just wondering how it may be different from CBT in managing chronic pain.
That is actually a very good question as well. So I think in our program, we use more on the mindfulness side. So we actually practice the mindfulness in each session at the beginning and the end of the session. And instead of trying to focus on the depression or anxiety or try to reduce it, we actually use the mindfulness and acceptance to allow it to be there, but continue to focus on the values. That may be a slightly different to typical CBT approach that we use exposure or use the cognitive restructuring to try to get or overcome the anxiety. So that is something a little bit different from the CBT. But actually, ACT is part of the CBT families. So it's totally valid that you'll find that it seems a bit similar to the CBT as well.
Right. So our audience definitely has the background in training to be noticing that. There's one more question on Professor Allen's presentation. It's about the digital intervention side. I guess one thing that we see in COVID is that accelerated the need for telemental health. So the question is about digital interventions are being applied more and more commonly, especially now in the COVID pandemic. And what are your suggestions if we apply digital interventions to aged population, older adults especially, who probably would have lower digital literacy? What is the priority we need to address in terms of the barriers to telemental health?
Another excellent question. So I guess right here, right now, being mindful in the present moment, I would say that in order to engage older adults in digital therapies, provide training, provide access to digital media, and then provide training in how to use it, or use the happy little mobile phone that everybody, including older adults, may have. If the barriers result in having to go to telephone-based, mobile-based therapies, then think about how to be very engaging in that kind of CBT ACT manner with your client, involving them very directly in their treatment, not so much listening, right? A lot more back and forth. Think on the telephone, shorter mindfulness exercises with frequent check-ins with the client so that you can ensure that they are in fact engaged and not doing something else. So in a larger, broader picture question, I think was embedded in that question. And I would say priorities would be for the world, all of our various countries, particularly, China, the United States, when we have the ability to make internet access accessible, we should. I think that all people, regardless of age and socioeconomic status, should have the ability to access the World Wide Web and benefit from its many, from the good aspects that go along with the web.
Yes, thank you so much. I can't agree more as to increase the accessibility to the World Wide Web. And I would like to, although this question is for Professor Allen, but I guess why you might have something to say about local experiences in using the technology who are delivering the mental health services. Would you like to chip in to respond to that?
Yeah, it's always a challenge there. And in our project, we actually train up some peer supporters. They are the young old volunteers. And we also train them to be the expert, or not the expert, the ambassador, the buddy, what we call them. And they can go to teach the older adults the technology and practice with them as well. So we find that for older adults, they always have the anxiety to use the technology. Maybe some of us also have this anxiety as well. So for them, they need to have a reason why I want to learn this. And they also need someone to be able to sit next with them and go through all of these practice. So the volunteers actually help us a lot on this side. So they can create a social connection. That's the reason why they need to learn the technology. And then they can practice with them and ease out their anxiety as well. So we find that it's quite helpful to build on.
One of the things I would like to see us do more is to have intergenerational supports and intergenerational treatments, because our young people know well how to use digital technologies, and young people can be a motivational tool for older people to learn and engage in these new ways of providing treatment.
Well, I agree with you both. One is on the community side, if we can have e-buddies when the younger generations are not by their biological parents. And then if the younger generations can be both a motivation and also a, let's say, offer instrumental help for their parents and grandparents in utilizing the devices. It's just making meaning for them to be motivated to use those gadgets. We have one more question coming in. Thanks, Professor Allen and Ms. Kwok. In your experience, may I know how do you address emotional avoidance, which may be quite common among older adults, as in they are sometimes unwilling to talk about their feelings, or maybe don't have the vocabulary to describe it? So any of you can start the answer, when you're ready.
I will pitch it to YY here in just a sec. Go in through the back door. Talk about all those, aches and pains and, creaky knees and, headaches and eventually emotions may follow. What would you say?
Totally agree. The body sensation is actually a gateway that we can get access to the emotion. So we don't necessarily that we go directly to the emotion and say, you feel painful, you feel depressed. So that's one way we can get around it. The other thing we may want to consider is sometimes people avoid because they find it helpful. So it doesn't necessarily that it's not helpful, and we need to adjust every avoidance in our sessions. So maybe we are only focused on the avoiding behavior that actually create more suffering in their life. On that area that the older adult may be more willing, or they can reason why we need to talk about the emotion. So that's one thing. The other thing is people tend to avoid the things that they feel insecure or scared of. So for them, they may feel fear about their emotion. So provide lots of validations, reassurance, and the empathy in the session actually cultivate the sense of secure. So help the older adult to in touch with his or her emotion as well.
There are also emotion wheels, right? So culturally adapted emotion wheels to sort of start easy on exposure to talking about emotions through, physiological symptoms, and then maybe provide some psychoeducation and mental health literacy training by use of tools like emotion wheels.
Right. That definitely opened us up to more possibilities and angles to be looking at the emotional avoidance. So we have tools such as emotional wheels, where we can start with the easy ones to talk about, or actually validating the older adults' avoidance and saying it's very painful to face the uncertainty, and by giving them security, validating their feelings, then we gradually open them up. And I can see it will be a process that needs our patience and empathy and more understanding of the community. Okay, thank you so much. There are some questions where I see Professor Allen already answered in the chat room. So if you have more questions, welcome to still pulling. We can take one final question in our Q&A session. If we don't see more questions coming in, let me do a little promotion and remind everybody that your feedback is really invaluable for us to improve our services for older adults with mental health needs. And throughout this symposium, we've heard about the need to listen to the community and engage them by encouraging more participatory actions from them in the co-design of the program.